Greg and Pat from NewEdge Wealth. How are you? Good to see you. Today, we're very pleased to have my own personal doctor, Dr. Wolf, joining us. Thought it would be an opportunity to talk to someone who, interestingly enough, thinks about his profession very similarly to the way Pat and I think about ours. And Pat will tell us why this came to be.
And thank you very much for being here, Dr. Wolf. I get a lot of indirect advice from you through Greg, where I ask Greg a question and he asks you and it comes back to me. And very much in the same way that, like, in our practice, like, we think they're the three most important things for investors to pay attention to, above all else, because they really have a big impact on your outcomes, are fees, taxes, and time horizon. Like, those are like really basic things that people don't spend enough time focusing on. They focus more on who's telling them the great story. And when I think about how important financial health is, and then the other thing I think it's really important to me and everybody else is your physical health. And my sort of favorite thing to read about is I spend a lot of time reading about investments on when I'm not working. And the other thing I spend a lot of time reading about is health. And because I'm very interested in actually living a long time. And there's an incredible amount of information about health out there, which is why people like us hire people like you, because we don't know what to pay attention to. And we just don't know, like, what are the most important basic things to pay attention to. And so if someone's walking in your office, doctor, like, what would you say, like, the 2 or 3 most important things that they should focus on to have the best healthcare outcome, assuming that they're presently not sick?
Well, that's a great question, and I think another economic principle, which works in economics and equally works in medicine, is the concept of diminished returns for marginal gains. And for instance, in medicine, there's a few basic things which everyone knows, and you certainly can't sell for a lot of money, that are good for your health. Don't smoke, keep your weight down, eat healthy, and that's a thing we could get into for an hour. What do you mean by eat healthy? Never eat a piece of meat in your life, it'll cause cancer. Only eat meat, it'll prevent cancer. You're literally getting antithetical advice on what is good nutrition, for example. So when someone says eat healthy, what does that even mean? And exercise. 20 years ago, we just thought, well, that basically means cardio. Now it means strength, or zone 2, or whatever. So even within that whole spectrum of eat healthy and exercise, there's hundreds of different specific advice within that advice that everyone's kind of competing for. So when I say something, don't smoke, well, that's easy. That's sort of a digital thing. Like, it's yes or no. Either you smoke or you don't. There's not too much nuance about that. But if I say eat healthy and exercise, there's a lot of nuance about that.
So what do we do?
And at the end of the day, when you look at these things, for instance, for exercise, there's from observational data. The observational data means, you look at a population of 200,000 people, like, for instance, the Copenhagen Heart Study, where they just observed 200,000 people for decades to see what kind of cardiovascular and health outcomes they had based on how much they did cardio exercise. And you definitely see almost a U-shaped curve, which means if you're sedentary, you have bad cardiac outcomes. If you do a moderate amount of exercise, you have lower cardiac outcomes. And then the marathon runners and the ultra marathon runners start to have an increase in cardiovascular outcomes. So basically, a moderate amount of exercise is good. So as you do exercise more and more and more and more, you start to actually get negative returns. So as I said, for most of these things, and this curve definitely is there for strength training. people who do moderate amount of strength training have the best outcomes. People who do a lot of strength training actually have an increased mortality. So a lot of
You just made my day, doctor. I don't have to step it up. I'm like, I just try to do enough.
This is the problem. 90% of people who come to my office, right? Because these people are already motivated for good health. They already do all this stuff. They're 90% there. And that's about it. There isn't that much more you can do. In fact, you can start to get negative returns. But the problem with health is people want more. And that's where it's this kind of, and I don't mean to use this word, this may come off badly, and I don't mean this about my patients, but it's a greed. It's like, I want more life. I want to live longer. I want more health. This isn't good enough for me. And that's where people get into trouble.
Yeah.
It's where, because of this tremendous desire for more, they lower their threshold for evidence and for the truth, so that it's wishful thinking to buy something that they wish they had.
Let's pivot there, because obviously we're in an industry which is, we're always, and our clients are always being sold something that's the newest and the greatest. And we see it all the time. And I think when they show it to us, we feel pretty qualified to evaluate it. Pat reads all this stuff, and one of the reasons we get to you is he asked me, hey, what do you think of this? And then I ask you, and there are some similarities between how we evaluate things and I think how you evaluate things. So when somebody brings something to you that they say, hey, I hear this is amazing, like, what's the approach you use to scientifically assess any validity?
Right. So, it's a excellent question, Greg, that you asked. Like, how do I actually evaluate this? And so this is where, and I think this is a very parallel to what you guys do. You have to take a bird's eye view of healthcare. You have to look at look at healthcare as an endeavor. It's a industry, and it's making a product, and the product is health. And what we want to know is, okay, in making that product, how well have we done? And a really good way of knowing this is to look at our past performance, as you guys say in the financial world. Let's look at our past performance. How have we done? And so, for instance, you guys know, if someone has a startup company, what's the likelihood that it's going to be the next Google? And if someone is invested in an ETF on the S&P, what's the likelihood that that's going to go up over the next few years? So you guys understand is we know these exact things in medicine. And this is what's really interesting, because I have patients who come to me all the time and they say, Dr. Wolf, I've done my own research, and I found that NAD is good for whatever. Like, I've done my research and I'm taking this supplement. So what's funny is when I ask them this question, what is our discovery rate in medicine? Just in all of medicine. So someone comes up with a new idea based on, say, some animal studies, physiologic reasoning, like it makes sense. We know a mechanism or a pathway, some anecdotal evidence. What's the likelihood that when we put this idea through phase 1, phase 2, phase 3, huge randomized placebo-controlled trials, that it ends up that it's both safe and approved? What's the likelihood? Not a single patient of mine has ever answered that question. Number one. Number two, they don't even understand why that's an important question, which to me it's the only question. It is so incredibly important. So let me take you through that, because you asked the question, how would I evaluate if an idea in general? So the first thing we have is, there's something in medicine, you've probably heard this, it's called evidence-based medicine. Evidence-based medicine is something that probably started 30 or 40 years ago. Evidence-based medicine is exactly that. There's different kinds of evidence in medicine. We already mentioned a couple of them. Animal trials, physiologic reasoning, anecdotes, and what we call observational evidence. And what evidence-based medicine does is exactly what you guys have done. It has looked at all that kinds of evidence and said, how reliable is that evidence? So you guys may know some of this already. If I ask you, how reliable is an anecdote? You have a friend, he's got knee pain, and he goes to a stem cell clinic, and they inject him with stem cells, and he gets better. He said, these stem cells work. How reliable is anecdotal evidence? What we know from the history is it's highly unreliable. And this is because of placebo effects, because your friend may have gotten better anyway, because most orthopedic conditions do get better anyway. So that kind of evidence is unreliable. So all of these rules are called evidence-based medicine, and it has another name. It's called the hierarchy of evidence, which is actually, if you Google hierarchy of evidence, you'll see a pyramid. And that pyramid has the best kind of evidence on top, which is a randomized placebo-controlled trial, which is extremely expensive and difficult to perform. And at the bottom is things like anecdotes and expert opinions and physiologic reasoning and animal studies. So this is called the hierarchy of evidence. And this is very well established. Basically, some evidence is more reliable than others. That's point one. Point two is something we call the replication crisis. This is also very well documented in all of science. The replication crisis is that academics who generate a lot of the rat experiments and ideas in medicine are unfortunately incentivized to make positive ideas, right? No one ever won a Nobel Prize for proving a medicine doesn't work, only that it does work. So a lot of these trials you can do, there's something called statistical p-hacking. There's a way to make the trials look positive. So the replication crisis is when scientists went to a whole bunch of really popular rat studies, essentially, did everything that was in that study to replicate the exact conditions in that study. Less than 25% of these studies were able to replicate. That's the replication crisis. So that's number two. So we talked about the hierarchy of evidence. We've talked about the replication crisis. Three is we have a very good model of our discovery rate in medicine from the pharmaceutical industry, because it's the one industry that is forced to take their ideas and do phase 1, phase 2, phase 3 trials on their ideas and spend billions of dollars on a single idea. So if you look at what the pharmaceutical industry does is they've got a bunch of nerdy scientists who are Nobel Prize winning chemists and biologists. They tell them, go scour from the rainforests to to their chemical libraries of millions of compounds and find the best idea on the planet that is going to treat, for instance, Alzheimer's disease. Find an animal model, find a physiologic mechanism. And they go and they find something. And then, of course, the CEO says to them, okay, is this the best idea on the planet? We're going to spend about $1 billion on trials on this thing. And the nerds say yes. So now, and this is also really well published data, out of 100 ideas that big pharma, the pharmaceutical industry has, what percentage of them will end up getting approved and be both safe and effective? Do you guys know?
I'm going to let Pat answer because you've asked me the question.
I think it's less than 1%, right?
Oh my God, Pat, you are awesome. Fantastic. That's exactly right.
I'm an investor, and so I know that there's all kinds of technology around trying to increase that number, but it's really low, and that's why drugs cost a lot of money.
Exactly. So remember, these are the best brightest minds on the planet with the most resources and the most money on the line. And they've been accused of cheating their trials. And with all of that, it's less than 1%. So what's the likelihood that Andrew Huberman has the cure for Alzheimer's disease, or Mark Hyman, or whatever influencer there is out there has the actual, I'm not saying they don't, but what's the likelihood that they actually have the cure? So summarizing what I said, and by the way, you can plug this into AI and you can actually get AI to think like me by saying this, using the principles of evidence-based medicine, comma, the hierarchy of evidence, comma, acknowledging the replication crisis in science, comma, and the success rate of the pharmaceutical industry of less than 1%, comma, what's the likelihood that NAD or whatever it is going to make me live longer?
I mean, look, that's really what we tell clients to do all the time. We're like, if you're going to pay 100 basis points, 1% fee, and it's an active manager, ask ChatGPT your chance of outperforming. It's zero. I can tell you, it's zero. Like it's zero. So you have a 7% chance of beating a benchmark as an active manager over time. 7. After taxes, 0. Like it's just math is the math. And so to summarize what you just said is, people who sign up for a concierge doctor generally are predisposed to like do the right things. So they come in healthier than your average customer is what you're kind of saying. And you tell them not to go to extremes with exercise, to do exercise, but being extreme doesn't help. And then with regard to looking at new medicines, what it sounds to me like is that you got to be really cautious about adding things to your protocols because they have to be proven. They have to be things that there's a lot of data on for a lot of years, because 99% of the stuff that comes across your desk is disproven.
Well, let me ask you this from a practical standpoint, right? Because we have clients that they really want to do direct deals that they get excited about. And we know that mathematically, it has a low chance of working, but they want to do them. So normally what we will do is we'll say, look, we're going to create a budget for this that will allow you to do some, but it's not going to take over your whole portfolio. The vast majority of your portfolio will be systematically invested by us. How do you handle somebody like us who's so excited about all these new things and wants to try things? How do you approach, what can you try? What do you need to know can you try, or what's off limit?
Okay. And this is what I wanted to speak to you guys about. And I think at this point, I may be veering into something I really don't understand, which is your world. This is how I see the difference between experimenting in healthcare versus experimenting on the market. And it all has to do with the expected returns, I think you guys call it in your field. If someone invests in a startup company and it does hit, it could be a 500%, like a ridiculous amount of returns. That doesn't happen in healthcare. Even if you did find something that was the fountain of youth, what's it going to give you? A few more years? Like, it's never going to be ridiculously effective. Nothing in healthcare is that ridiculously effective. So I think that's very different, right? So when people are looking at their benefit harm analysis, if they do win on one of these things that they put a little bit of money into, it could have a tremendous amount of return. In healthcare, it's not like that. And of course, in healthcare, and this is the biggest con, and this is where patients really are missing out, is, and this attitude I see pervasive in all my patients. That was a Freudian slip. I said all my parents. The biggest mistake is they when I press them, they basically say there's no downside. It's natural. It's from nature. It's a supplement. It's only this. It's only that. That is the biggest logical fallacy I see with all patients. And this is it's teaching people basic physiology and how physiology really works. Now, unfortunately, on social media and all these other platforms, they teach people almost this magical kind of physiology. This physiology where, only good things happen. The stem cells only do good things. They only go in there magically and they just know to heal you. They can't do anything bad. Whereas in real physiology, things are more like a balance. If someone has an immune system, do you want to boost your immune system? Is it a good idea to boost your immune system? Well, you could get autoimmune diseases. You could get allergies. All of those things are a result of a boosted immune system. It can also cause blood clotting. So do you want a boosted immune system? And if we reduce inflammation, which is reducing your immune system, is that a good thing as well? Your immune system is used to fight off cancers and infections. So do you want to lower, it's most things in physiology are trade-offs. They're not good or bad. And that's the problem, is that people are taught this strange physiology that doesn't really, it's like a magical physiology. All I would tell your people watching this to know is if something is strong enough to help you, it's strong enough to harm you. That's how it works. So to answer, sorry to go off on a big tangent with your question.
That's it's strong enough. Let me say that again. Something is strong enough to help you. It's strong enough to hurt you.
Yes.
It doesn't take much to hurt you. The body is a delicate balance, right? It's a delicate thing. So it's a complicated system that we don't even really fully understand.
If you don't mind, let me make one other point, and once again, see how maybe this relates to the financial world. But another very important concept in medicine is that preventive medicine, or now what's being relabeled or rebranded as longevity medicine, which is just preventative medicine, which we've been doing for 60 years now.
Marketing is marketing.
Marketing is marketing, is the most difficult kind of medicine to practice because the benefit harm analysis is very different. So let me explain to you this concept because it's very, very important. And this is what people are really missing. And to summarize it in one line before I explain the whole thing is, don't mess with healthy people. That's what really it comes down to. So the benefit harm analysis for a healthy person is very different with the same treatment as it is for a sick person. For example, just say I have a medicine that prevents heart attacks, but remember what I said, most things are physiologic trade-offs. When you affect one pathway in your body, there's hundreds of different pathways that will affect. So just say that thing prevents heart attacks, but it causes cancer in 20 years from now. Now, if I give that to a 75-year-old person who's having heart attacks, of course I'm going to do it 100%, right? Because that's what's really important. In other words, you can give dirty drugs to sick people because they have everything to gain and less to lose. They're suffering or they're going to die. But you can't give physiologically dirty drugs to a healthy person because they've got decades and decades. You have to have a physiologically perfect drug, that this magical drug that they're talking about that doesn't exist, that has no trade-offs and only does good things. So do you understand that point, that the benefit harm analysis?
It's brilliant. It's brilliant. I mean, you take risks with drugs when you are at risk. And when you are not at risk, when you have no risks, you don't go take drugs that could cause an imbalance in your body now or later.
Exactly.
It's not worth the risk. Is that right? No.
Yeah, 100%.
There's a lot of similarity, not to interrupt, but it's like optimizing the portfolio. Like, you don't take risks. If you got somebody that absolutely needs to make a certain amount of money in a short period of time, or everything is going to go sideways, well, then you take risks because the other outcome is bad. But if you have somebody else who's going to be fine with a lower level of risk in the portfolio, then you do that. And,
right, because you don't need to do it. I got one question for you, and it's something. So when we're sitting down with families, and we very often spend a lot of time with their kids, their adult children, and try to teach them how to best practices for managing wealth so that they are good stewards for the family and learn. And the first thing I talk to them about, as I say, the first question you need to do is you need to ask me. They need to ask me. I said, how do I get paid? I said, because I really believe incentives drive outcomes. And if you're sitting across from someone who is incented to push you in a certain direction, they're going to. Not doesn't make them bad or anything else, but that's just how systems work, right? And so in our business, we're pure fiduciaries, and we either earn an asset-based fee or a fixed fee, and we don't take a scrape of anything, meaning that we don't get paid more if we buy you a private equity fund or put you in cash. It does not affect our comp. Everybody's biased. There's always conflicts, but like close to being unbiased as we can be in our space. Describe for me, like, how you're compensated and how you see conflicts in your space, because most of us don't really understand medicine and how that works.
Yeah, I mean, it's definitely 100% equivalent in my space as well. And most people are actually very well aware of this. And actually, this has a name. This is called the specialty bias. And it's not only a financial conflict of interest, it's actually an intellectual and a philosophical conflict of interest. And the specialty bias, actually, to give you a little bit of history, was a term developed by a very famous psychiatrist. You probably have heard his name is Abraham Maslow. You've heard of like Maslow's pyramid of needs.
Yeah. Yep.
But the other thing that Abraham Maslow noticed as a psychiatrist was in 1950, with the invention of the first antipsychotic medicines, Thorazine, which was really a very heavy medication. And if you saw or read the book, the One Who Flew Over the Cuckoo's Nest, the psychiatrists were using this pill in everyone who was like very psychotic and really needed, to people who just had mild anxiety. So he came up with the saying, which you have heard, if all you have is a hammer, everything looks like a nail. That's actually called Maslow's hammer. So you probably heard all this stuff before. It actually came from him. It's the specialty bias, because specialists see the world through their specialty. They are financially, philosophically, and they live in echo chambers. They hang out with other psychiatrists who all validate their beliefs. And this is what happens within medicine. So if you're a longevity doctor and you go to longevity conferences and hang around with other longevity doctors, you just think it's the greatest thing in the world. You hear very little negative and only positive, and your whole world is based on, I can make people live longer. I can make you live to 120. It's based on that whole belief. And if they can't, their whole existence means nothing. Whereas for me, I'm not a longevity doctor. I'm a general internist. I have no stake in any game. If this thing doesn't make somebody live longer, that's okay. So the one thing I always tell my patients, which may be similar to what you guys are doing, is fine, go see longevity specialists and go see stem cell doctors and go see, whoever it is, and spine surgeons or whoever it is. But have a general internist who doesn't have any skin in those games, who's not selling supplements out of their office or doing IV NAD out of their office or doing cosmetic procedures or whatever the hell it is, like someone who just has no other conflicts of interest, that is as unbiased as possible, and at least get a second opinion from that unbiased entity about what's going on. And to another thing, to your point, the way concierge medicine works, most models work, is it is a yearly fee. So the rest of medicine, if you think about it, that does the what's called fee for service is the traditional model. And it doesn't matter. You could be an acupuncturist or you can be a neurosurgeon. It's all fee for service. The more office visits, the more money I make. The more sick I make you look to drive more office visits, the more money I make. The more procedures I do, the more money I make to drive more office visits. The whole thing is a cycle. So there definitely is a huge conflict of interest with any specialist to drive more money that way. Whereas if you're a concierge doctor, is just a yearly fee. So for me, my incentive is if I'm there for a patient to answer all their questions all the time and available, and I gave them good, honest advice. And if I'm lucky, the next year they say, I want to sign up with this guy again. So I'm valued on my performance, not necessarily on how much I drive the whole system. So yeah, definitely a yearly fee is less biased. There's a problem now within concierge medicine where even the people taking the yearly fee are now biased because to take that extra money from a patient, they say to themselves, yeah, but you know what? I really need to justify this extra money that I'm charging a patient. So yeah, I'm going to pretend I can make them live longer. So now I've been doing concierge medicine for 25 years. It wasn't like this 25 years ago. It was just about sort of giving good people just good advice and being available.
But it's funny because the parallels to our business are like, it's just convincing somebody that like, you're going to beat the S&P by some amount over time when statistically there's no probability the guy could do it. And yet our entire industry is outselling it every day. Like it's always happening. Like, and I literally like, and you can go to chat, you can take your statements, drop them into Chat GPT and it'll give you all the answers and clients won't like their answers. They're not doing that. Yet that's still what they're sold because that's the incentives of the industry. And so what you're saying is like the neutrality of them paying you an annual fee for service to give them good advice and everything else. You don't need to go do all kinds of other crazy things to keep people excited. And you won't do it because that's not the right thing to do. You're supposed to focus them on the basics, which you've articulated today, which is a conservative strategy towards using drugs, right? That's, not only using things that have proven track record, have gone through phase 3 trials, not stuff you learned about online. And you're saying moderate exercise and to take less risks with medicine if you're healthy. You really shouldn't be taking lots of risks. You're healthy. That should only be something you should be considering if you're not healthy.
Oh, we have two plain speakers here, Pat Dwyer and Dr. Islam Wolf. And look, I really appreciate all the time and thought you give me to my questions. And I thought it would actually be great to share your brain with a broader audience. And I really do see so many similarities between the way you think about and approach kind of medicine and your practice and the way we approach finance in our practice.
Well, Dr. Wolf, I just want to say thank you so much for coming and speaking with us today. I've heard about you so much through other clients and Greg, and you are as smart as advertised. For anyone looking for a phenomenal new doctor, Dr. Wolf is in private practice on Lincoln Road, and we would be happy to give you his number, or you can just go to Google and get it. But thank you very much for your sage advice. We appreciate it. Health and wealth, they go together, and one needs to be thoughtful in approaching both of these markets because advice is often tainted. And you really gave me some real new insight into your business, which I really appreciate. Thank you.
Thank you.
Thank you, guys. It's been a pleasure speaking with you.